Subcommittee. It is March the 14th, and we have 3 bills on the agenda today, 930 to 1194. We're going to start with House Bill 933, Behavioral Crisis Response Services 988 Trust Fund Fees. Aaron, if you can talk us through the...
I think you froze up a little bit, but did you ask me to?
I did. My apologies that I froze. House Bill 933, which is the behavioral health crisis.
Okay, this bill establishes a state 988 fee that has a structure that's
crisis response services 9.
The bill establishes a state 988 fee that has a structure and application similar to, nearly identical to the state's 911 fee. This fee will be set at 25 cents and applied on specified 988 accessible services in the state, which is generally phone lines and prepaid wireless services. The fee revenues will accrue to the 988 trust fund. And under the bill, will require that the state 988 fee for switched local exchange access services, commercial mobile radio services, and other 988 accessible services will be established at 25 cents per month, payable when the bill for the specified service is due. Each telephone company and 988 service carrier must act as a collection agent for the fund with respect to the fees and remit the collected fees to the comptroller on a monthly basis. A 988 service carrier must keep records of collected 988 fees for at least 4 years after the fee is remitted, as entitled to retain 0.5% of the fees it collects to cover administrative expenses.
I created a bad bill spreadsheet in your Google.
A 988 service carrier means a provider of CMRS or other 988 accessible service, which includes a telephone service or other communication service that connects an individual who dials the digits 988 to an established public safety answering point. This does not include a telephone company. Under the bill, the comptroller is required to adopt procedures for auditing 988 fee collection and remittance by telephone companies and CMRS providers, and to adopt regulations for implementing the 988 fee. There is a reprint that was provided, and this is actually drawn to the Senate cross file. This reflects the bill as passed on second reader today in the Senate. If you go to bill page 3, there is an amendment that on page 26, this provides that the 988 trust fund may be used only for carrying out the purpose of the fund and also for any related administrative expenses of the comptroller. There's new language on bill page 4 after line 11. This provides that the comptroller must distribute to an administrative cost account the amount necessary to administer the fees and to cover the expenses of conducting audits from the 988 fee revenue that's collected and remitted to the comptroller under this bill. The amount distributed to the administrative cost account may not exceed for fiscal years 2025, 26, and 27, 6% of the fees collected by the comptroller, and for fiscal year 2028 and each fiscal year thereafter, 3% of the fees collected by the comptroller. And then after making this distribution, the comptroller must deposit the 988 fee revenue into the fund. There's clarification language on lines 15 through 17 that provides that a 988 accessible service means telephone service or another communication service that connects an individual dialing the digits 988 to the 988 suicide and crisis lifeline. There are additional amendments. It's a blank page after bill page 4 that provides that a subscriber who is enrolled in the Lifeline program may not be required to pay a 988 fee. There's additional amendments that provides that the comptroller is not required to deposit the money remitted into the fund. I think that's the money's still going into the fund. It's just not on the comptroller to actually remit that money into the fund. And then there is, so the bill as it would apply to prepaid wireless, that provision, those fees on prepaid wireless will not take effect until July 1st, 2027. But the rest of the fees on the the other accounts would take effect July 1st, 2020, I'm sorry, October 1st, 2024.
All right, thank you, Erin. And for the members, it's been a while since we heard this bill, but this was to create a sustainable fund for the 988 service. Do I have a motion on the amendments?
Move the amendments.
Second.
All right, they've been moved and seconded. Let's go ahead and open it up for discussion. Delegate Alston.
Thank you. So I was just a little confused by the last part about the comptroller shall collect the fees, but is not required to remit them to the fund. Could you explain that or elaborate a little more on what that exactly means?
I'm going to punt to Adrienne Bridenstine because she can explain the logistics of how it would get into the fund.
Okay.
Good afternoon. Can you guys hear me?
Yes.
Great. I will admittedly, I'm Adrienne Bridenstine, by the way, with Behavioral Health System Baltimore. So I admittedly am not an expert on how the comptroller sets up collecting fee, but it's my understanding that they are going to collect the fee through two main mechanisms. One is through the telecom companies, and that's like your AT&T and your Verizon, and the second is through prepaid wireless phones. They require the telecom companies and the retail companies that sell the prepaid wireless to assess the fee, and then they collect it, and then the comptroller collects it from them, and then puts it into the trust fund. That is my very rudimentary way of understanding and explaining it. I don't know if there's anyone here from the comptroller's office that might be able to add to that, but the money that is collected from the comptroller's office is deposited into the 988 trust fund. So that I hope that answers the question.
Delegate Alston? Did that clarify or?
It does, but I thought and maybe I heard Erin wrong. I thought she said they're required to collect it, but not remit it. So they do have to remit the money to the fund.
Yeah, so the language that was stricken was the specific mandate that the comptroller deposit the money remitted in the fund. I will find out why that was stricken, and how it goes. I mean, it's probably just a logistical issue, but I'll find out how it goes. Maybe it's just someone. Delegate Feldmark's on.
Looks like Delegate Feldmark is here, so she might be able to answer that question. Thank you.
Thank you, Madam Chair. And I will admit the technicalities with the comptroller's office are not my area of expertise either, but I believe this was related to establishing the administrative cost account, right? And so some of the fees collected will be going into that account, not necessarily all of it will be going directly to 988. So I believe that may be why that specific language was struck, but that is a little bit of conjecture based off the conversations that we had. So
thank you, Delegate Feldmark. And I think this might also go back to the language on page 4, but we'll get some clarity because on page 4 it speaks to shall distribute to an administrative cost account the amount necessary to administer the fees and to cover the expenses of conducting audits under this section. So it sounds like we're just trying to make sure that we have a flexibility in covering our bills as well as securing the 988 trust fund and 988 services going forward. But we will get clarity on that.
Yeah, the bill's clear that the money goes to the fund. I think it's just saying how it gets there.
It's just that the technical path.
Yeah.
All right, thank you. Are there further questions on these amendments? All right, they have been moved and seconded. Delegate Alston, are you comfortable with if we just get some clarity? Delegate Hill. All right.
I'm looking at the documents and I'm just going to ask if you resend them because I don't have this reprint. Thank you.
Yeah, I will send them right now.
Delegate Hill, are you comfortable with us moving forward, or do you want me to move this bill to later in the?
No, you can go ahead. I mean, everyone else seems to be comfortable, but I'm not I'm not seeing at all what we're talking about. I've got different bills. I've got
Okay, we'll send them to you and make sure you've got them in front of you. Delegate Riley.
I as well, I don't have the agenda or anything for this particular meeting. But when was it sent? So I can, I mean, I have the link and everything, but I don't have the agenda and what bills were to discuss.
117, I think most of it was sent.
Yeah, from
117?
Aaron.
Okay, thank you. So is that what we're on? I mean, what bill are we on?
We're on House Bill 933.
933. Okay, it was sent on.
Yeah, the email was sent at 1:17.
Okay, thank
I'm
you.
sorry, that's just how today.
Thank you.
It's just crossover week.
I get it. I'm good. Thank you.
All right, thank you so much. All right, so the amendments have been moved and seconded. All in favor, say aye.
Aye.
Anyone opposed? Go ahead and raise your hand
All right.
in the chat. Do we have a motion on the bill as amended?
Move the bill as amended.
Second.
All right, it's been moved and seconded. Any further discussion? All in favor, say aye.
Aye.
Anyone opposed? Go ahead and raise your hand in the chat. Delegate Hill, do you want to,
Yeah, I'm looking at, I've got public health, I've got final reprint 988, I've got final with stamp and final reprint, which is what I had. I don't have anything about whatever this bill number is.
Sorry, my fault. Again, I want to call this 988 because it's about 988. So if you pull up final reprint 988, that's about this bill.
No, I don't have a final reprint 988. Oh, I see,
No.
final reprint 988. That
Okay.
is this bill?
Yeah, because I want to call it 988 because it's about
933.
But when I hit that one, it says 974, Gazoni bill.
Yeah, okay, so it's drawn to the
With
Senate
stamp.
cross file, which is Senate Bill 974. So it's the bill we're
Okay.
talking about.
So we're adopting the Senate amendments as it passed second reader.
All right, so, okay. Sorry.
Who's on
That's
first?
okay.
Right?
What's on second?
Home base. Home plate.
The Senate bill.
Let me go to Delegate Martinez and then Delegate Hill. We'll make sure that you've got clarity. Delegate Martinez.
I just wanted to thank the bill sponsor since she's here for the bill. 988 is so critical, so important, and us providing a dedicated funding mechanism for that is going to save lives. So thank you, Delegate.
Thank you.
And I'm fine. I just didn't, again, it wasn't the bill we were describing. I needed to understand what we were talking about. Thank you.
Absolutely. And we want to give you the time. We know things move quickly this week. So I appreciate you asking the question so we can get clarity. So House Bill 933, which refers to 988, which is amended to look like Senate Bill 974, passes unanimously. All right. We really could write our own comedy sketch. All right, so we're going to move to House Bill 1194. This is Clinical Staffing Committees and Plans Establishment, the Safe Staffing Act of 2024. This is a bill that we heard yesterday, just to clarify. And so Erin, if you can walk us through the bill and the amendments.
So this is actually drawn to the House bill, and there is a reprint of the bill as amended. So the bill as amended strikes the bill as introduced. So instead, the bill would require each hospital licensed under Title 19 of the Health General Article to establish and maintain a clinical staffing committee that has equal membership from management and employees. Each clinical staffing committee must develop a clinical staffing plan for the hospital that establishes the appropriate number of clinicians needed to administer quality healthcare by setting. In developing the staffing plan, the clinical staffing committee must establish, based on the patient population of the hospital, specific guidelines or ratios, matrices, or grids indicating how many patients should be assigned to each registered nurse by unit or setting, and the number of registered nurses, licensed practical nurses, CNAs, certified medical technicians, environmental science workers, service workers, and ancillary members of the direct care team that should be present on each unit during each shift. To the extent practicable, the guidelines must be based on national evidence-based standards. On or before July 1st of each year, each hospital through the Clinical Staffing Committee must conduct a review of the clinical staffing plan to evaluate the effectiveness of the plan during the immediately preceding year and update the plan to ensure that the clinical staffing plan continues to be appropriate and effective. The hospital is also required to provide its clinical staffing plan on request. And the amendments also would exempt state hospitals.
Delegate Hutchinson.
Thank you, Madam Chair. Boy, it feels like it was just like 16 hours ago we heard this bill. If I recall, though, there was some discussion with MHA and maybe taking out a word or two. So did any of that occur within the last 16 hours? Any update from the sponsor delegate?
Delegate White Holland, go ahead and answer that. I know we've got a lot of the stakeholders here and you all have been doing yeoman's work and communicating. So if you want to go ahead and speak to the discussions.
Yes, thank you, Madam Chair, and thank you, Delegate, for your question. Following the hearing, I shared the amendments that you see before you. There was a commitment that they would share it with their fellow members and provide further feedback. I hadn't received anything yet, but I will defer to our colleagues at MHA to see if there's anything that they would like to elevate stemming from them circulating these amendments.
Yeah, Delegate, we've shared it with some members, but we didn't know this was going to be voted on today in 16 hours. So we have not been able to fully vet this.
And Mr. Whitaker, I saw your hand up as well.
Yeah, just want to echo what Pegeen said. We received the amendments the night before the hearing, and then the subcommittee was the day after the hearing. We're a member-driven organization, and we just need time to run it by the members.
All right, I appreciate that. I also know that you appreciate that we are in crossover week. So I am going to hold this bill, but I do want to have the discussions now so that we can get any further questions or concerns on the record. And then I'm going to ask I'm going to ask that you circulate it with your members because we are going to bring this bill back and we are limited time sensitive to the crossover schedule. Let me go to Delegate Chisholm and then Delegate Hill, and then we'll go back to Delegate Hutchinson.
Thank you, Madam Chair. I think this is one of those situations where sometimes we want to help so bad that we end up hurting. And I think this is one of those bills, and with all due respect to the bill sponsor, because I know she just wants to help. I do have a good relationship with Brett McCone, who used to be with the Maryland Hospital Association, is doing an incredible job at BWMC. And, I think all of these hospitals are trying to solve these problems on their own. And I think this is just adding yet more bureaucratic regulations on top of them when, they know what their own needs are. I think in-house, they can figure a lot of this stuff out. I don't think any of our hospitals are failing people on purpose, and it doesn't solve the problem that we're all trying to solve, and that is a workforce shortage. They know where those shortages are. And that's just, from my gut, my feeling on this bill. I know what it aims to do. I think it misses the mark, to be honest with you. Thank you, Madam Chair.
Thank you, Delegate Chisholm. Delegate White Holland, I'm going to go to you and then back to Delegate Hill.
Okay, thank you, Madam Chair, and thank you, Delegate, for elevating your thoughts and your feedback here. I would just emphasize to colleagues here that if anything, it was our workforce, our nurses, those that serve and work on the front lines, that desire to be a part of the decision-making table. That's what this bill does. It ensures that their voices are heard as part of these staffing committees, and that what they share is involved and informs the staffing plan. And so, this is not to if anything, bog down our hospitals. In fact, you heard in the testimony that they already provide staffing plans and ratios through suggested guidelines. And so we just simply want to ensure that in the decisions that are made at those particular levels, that the workers, that those who serve patients and who work directly with patients are represented. And so if this is something that is already being done, this is an opportunity for us to ensure that those voices are a part of that table. So that's what this does to make sure that there's greater representation. Thank you, Madam Chair.
Thank you, Delegate. And I will remind everyone in this discussion, of the comments of our chair at the end of this hearing yesterday, that we do need to recognize that, that some of the stakeholders who are directly impacted by what we decide to do are watching what we do. So Delegate Hill.
Thank you, Madam Chair, and so I know I had a discussion with the sponsor yesterday, and I want to throw the thought out to the stakeholders who are on here who are opposed to the bill. Because as I read it, and I know this is a little different from how it was originally, how it came in, where the original bill said that a pre-existing committee might serve this purpose. And I thought that was a good piece. It says that you have a clinical staffing committee and that you have an equal number of, administrators and staff, and that you have guidelines. So what I had suggested is that where it says specific guidelines or ratios, that perhaps it would be softer on the hospitals if we struck the word specific, and I don't know how the sponsor feels about that, so that it would say that they must have guidelines or ratios, matrices, or grids indicating, and this is just aspirational. And again, from the testimony, it's not different from what they already do. They already have aspirational goals about nurse and patient ratios. They may not have aspirational goals about full staffing of the floor all the way down to the non-direct care team members, which is what this would ask for. And so, that's my first thought. I would really like to have at least one of the opposition, again, when they present this to their stakeholders, explain that this is, I'm not clear how this is significantly different from what they're doing, other than the makeup of the committee. And then the second question, I just wanted to have clarity on why we're excluding the state hospitals.
Thank you, Delegate Hill. And I do recall from the bill hearing yesterday that there was a suggestion of changing specific to suggested. And I think we made note of that as well. I do want to get all of the members' questions, and then and Delegate Hutchinson, I have not forgotten you. I will give you a second bite at the apple. I just want to get everybody who had their hand up. Delegate Lewis, you had your hand up. Delegate, also,
Yes.
we answered your question. Your hand went up and back down.
It hasn't been answered, but it's the question that Delegate Hill just asked about why.
Okay, the state hospitals. All right, Delegate Lewis.
Thank you, Madam Chair, and thanks again to the bill sponsor and all the stakeholders. I'm curious. I think this bill is a great idea, and I also understand some of the trepidation. So I'm curious. 2 years ago already, we passed legislation to establish a commission to study the healthcare workforce crisis. And of course, we all know we're still in that crisis. We're still studying. I'd like to know, number one, what's the status of the report from the Commission on the Workforce Crisis? Is my first question. Who can answer that? Where's the report?
Mr. Whitaker or Ms. Townsend? No.
No one can answer. Okay, so the Commission to Study the Healthcare Workforce Crisis is a state commission, and I do believe the MHA is a member of that state commission, as well as many other stakeholders. The reason I ask is because I expect that commission will issue a report with recommendations about staffing, about how hospitals can effectively, efficiently, humanely staff their hospitals, what their targets would be, what the shortages are, which cadres need particular investment. And so I expect we'll get a really fine-grained picture when the commission's final report comes out. And it's also my expectation that between now and the time this report comes out, which for some reason nobody in this room seems to know anything about, so including people who are on that commission, between now and the day that final report comes out, we're still going to be in crisis. We still need to be doing what we can to make sure that hospitals have the staffing they need, and that the cadres who provide healthcare services are effectively deployed and supported and all that. So it seems to me this bill is an opportunity for us to tackle one aspect of the workforce crisis, that staffing, and to do so in a way that is inclusive, that leverages the insights, expertise, perspectives of people who are doing the work. And so my sense is, this is worth doing until we get that final report. So I would ask if anyone who is opposing the bill can respond. Is this bill an opportunity for us to tackle the healthcare workforce crisis now while we wait for that final report? Thank you, Madam Chair.
Thank you, Delegate Lewis. I'm going to take Delegate Hutchinson's question, and then we're going to circle back. Delegate White Holland, if you've got an answer on the omission of state hospitals, I'll come back to you. But Delegate Hutchinson.
I have a question and a point of clarification. First, the question is, does this have a sunset?
No.
No.
There's no sunset. Okay. I just want to, yesterday there was a lot of discussion from MHA about they're going to be mandated to add additional staffing. They're going to be mandated to follow the recommendations of this commission, and I understand and I respect their comments that, well, they would do so anyway. But I do want to go on record to make sure this bill is not mandating anything, is not going to force the hospitals to necessarily change any of their staffing based upon the recommendations. I sort of see this as a bill that is getting the employees to be able to give some input into the staffing within the hospitals, but that's the scope of the bill, not mandating our hospitals at any way to add or change their staffing patterns based upon this commission. Is that correct?
That's correct, Delegate Hutchinson. It's bringing more stakeholders into the conversation on creating those guidance documents.
Thank you.
Thank you very much. Delegate White Holland, let me go to you for some perspective on the questions, and then we'll go to Ms. Ericott and then Mr. Whitaker.
Yes, I was just about to mention that I believe Ms. Ericott can expound upon further the commission report and the recommendations or the work they've done thus far. As it relates to state hospitals, I would rather, in what we can do if we are intending to hold this bill, I can make sure that I have the appropriate response from the Maryland Department of Health, more specific language from them that can speak to that particular issue. I have more of a general sense, but want to make sure that I am correct in what I share. So I will be sure to have that information available for the committee directly from MDH.
Perfect. Thank you very much. And we're going to hold this bill until tomorrow. So we will be bringing it back. But let me go to Ms. Ericott and Mr. Whitaker so that, again, we can get all of our questions on the record so we can have answers for the subcommittee.
Thank you, Delegate Bagnall and members of the committee. My name is Lorraine Ericott, Senior Policy Analyst with 1199 at CIU. We are really grateful to be part of a lot of the work groups and commissions that have been convened to address the healthcare workforce shortage. And the Commission to Study the Workforce Crisis had multiple subcommittees that really address this comprehensively. So we really want to applaud the conveners for that and state delegates and senators for joining us in that conversation. That workforce actually did create a final report, which I can make sure to send the link to you all, that includes in detail all of the conversations and input that was provided by all members, including 1199 at CIU. So what I really appreciate about this healthcare workforce crisis report is that they have a huge emphasis on the lack of data that we currently have. So trying to understand the turnover rate, average length of tenure for shortages, Also addressing the education pipeline and seeing if there's any limitations to people receiving their license or certification for specific titles, so that we can get those workers in their field and working. Thinking about educational institutions and training programs, and then also the student loan repayment program and how we can strengthen that, and also looking at specific needs for rural healthcare systems as well. What's really interesting is what's not really discussed is how do we retain workers and what's causing healthcare worker burnout. And those answers can't be held by people who are not close to the problems. And so what this bill really does is make sure that healthcare workers who are experiencing it know what they need in their workplaces to provide the best care. And in yesterday's testimony, we actually heard from one of the hospital members at University of Maryland describe a governance structure that's very similar to a staffing committee, right? So a lot of hospitals might already have structures in place that resemble staffing committees to address staffing ratios, staffing plans, guidelines to make sure that they can improve care and make sure that workers are also having safe working environments. What this bill will make sure is that every single hospital has that opportunity to create staffing committees, to create collaborative processes, because right now, many of our members, as 1199 is also a member-led organization, are saying that there's not avenues that are transparent and collaborative for them to meet the issues that they've been raising for years, right? And being a part of these task forces and work groups, this is the only solution that is worker-led that has been offered for the state of Maryland to finally implement. And just to also answer the question about state hospitals, we are really grateful to work with Maryland Department of Health on amendments. And one of the things they had mentioned that I think I would actually just like to refer you all to their testimony for this bill. They mention a specific guideline from CMS on federal regulations on state hospitals that they were concerned about and might be the reason for the exemption, but would be good to kind of check with them on that as well. And I think that's all I wanted to kind of share right now. Thank you.
Madam Chair.
Thank you very much. Yes, Delegate Lewis.
Thank you. Thanks, Ms. Arcott, for that overview of the final report. I didn't realize the final report had even been issued. Should have been hand-delivered on a silver platter to every member of this committee. But in any case, Madam Chair, if I may, it still seems to me that, and in fact, based on what Ms. Arcott said, this bill seems to present an opportunity for us to learn about a retention strategy. And that strategy is including healthcare employees in the staffing process, since the Workforce Crisis Commission and report didn't really address retention strategies. And so if I'm seeing this bill accurately to the sponsor, this looks like a potential retention strategy. And if that is the case, is it worth considering a reporting requirement of some kind? I'm looking at the reprint. I don't see reporting, and maybe I'm missing it, but maybe a question just asking, when that something like, do hospitals that, what are the staffing outcomes? Are staffing challenges resolved or addressed, improved, in hospitals that engage employees in the staffing process? Just a question for the sponsor. Thank you.
And Delegate Lewis, because I know we're bringing this bill back tomorrow and we are time sensitive, I'm going to ask if you will talk offline with the bill sponsor, because I also don't want to do anything that would sort of upend the conversations that have already been happening between the sponsor and the stakeholders. So I'm just going to put a pin in that because we are going to come back tomorrow and ask if you can have that offline conversation and just find out what the previous discussions have been. I do know that we have the Department of Health here also the Hospital Association, because I think that Sarah may have some answers for us. Then we'll go to Mr. Whitaker. Then we have one more bill, but we will bring this back tomorrow. So I encourage all the stakeholders, talk with your members and be ready to have the conversation, because it does feel like the will of the committee is to move forward. Ms. Case Heron and then Mr. Whitaker.
Thank you. So on the report, we will be forwarding that to Erin so that it can get to the group. Not quite on a silver platter, I'm sorry, Delegate Lewis, but we will get it to you as soon as possible. And we'll make sure that you're on that email when we send it to Erin as well. Regarding the healthcare system is bound to the Joint Commission and the Centers for Medicare and Medicaid Services, CMS regulations that don't allow external stakeholders to participate in staffing determinations. Additionally, because we are part of the state budget, some of our staffing is rolled into that budget conversation. So those were kind of our two flags that were, I think the CMS piece was in our testimony as well.
Thank you very much. And Mr. Whitaker, you have the last bite at the apple on this one today.
Great, thank you, Madam Chair. Sarah, if I could kindly ask you to get those guidelines and rules that you mentioned from CMS, that would be really helpful. And then I think additionally, what we're ultimately saying is this bill doesn't get at the staffing crisis. It's a staffing crisis that affects not just healthcare facilities here in Maryland, but across the country. And I think that's evidenced by the fact that there is that collaboration in Maryland facilities and hospitals, as well as state facilities, and there's still a staffing shortage of state facilities and private facilities as well. So I think that's our ultimate point, but we're happy to continue this conversation.
Thank you very much. And I think you know that the point of the bill sponsor and several members on here is that this is an opportunity to get the folks who are at the granular level at the table helping with addressing the workforce crisis. And I hope that we will continue to have those discussions through that lens. Thank you, everyone. We will bring this bill back tomorrow. So once again, check your email, listen on the floor, because things are moving quickly. We have one more bill we're going to discuss today. This is we also heard this bill yesterday. This is House Bill 1396, Drug and Alcohol Treatment Programs, Discharge of Patients and Referral Services Standards. We have heard a similar bill in the past. Essentially, it is looking at how we can address folks who have completed their treatment in their treatment program, but don't have a place to transition to. Erin, if you can walk us through the bill and the conversations we've had, and then we're gonna have a conversation, because I understand there was another stakeholders meeting previous to this. So let's get an update on where we are.
Okay. The bill requires the Maryland Department of Health to establish by regulation standards for the discharge of patients from treatment programs and referral services offered to patients by certain treatment programs. By December 1st of 2024, the department must submit a report to the Governor and General Assembly on the status of the regulations to implement in a plan for enforcement of the bill. Specifically, the bill requires the department to establish by regulation standards for the discharge of patients from treatment programs. And treatment programs are defined in the bill as an entity that provides treatment, care, or rehabilitation for patients who show the effects of drug or alcohol abuse, represents or advertises itself as an alcohol or other drug abuse treatment program, and is required to attain a certification from the Behavioral Health Administration to provide drug and alcohol treatment services in the state. The standards that are required to be established under the bill must require that a discharge from a treatment program be appropriate for the patient's mental health or substance use disorder diagnosis, and prohibit a treatment program from discharging the patient if the patient will be homeless or reside in a homeless shelter on discharge, needs to receive care in a residential program based on the assessment that's conducted on the patient, and require a treatment program to refer the patient who meets the criteria of the bill to receive care in a halfway house that provides ASAM level 3.1 services or an appropriate recovery residence if the patient is willing to receive the level of care. before or at the time of discharge. They must require a treatment program to refer and facilitate entry of a patient into a program or service identified as a need for the patient under the assessment that's conducted. And that would include certain programs or services. It also requires that if the patient is transitioning from one residential treatment program to another program, require that the referral for any outpatient services by the receiving treatment program be in place before the transfer of the patient. And if the patient is transitioning to a homeless shelter, require that the referral for any outpatient services not provided by the shelter be in place before the transfer of the patient to the shelter.
Thank
I guess
you.
we move the amendments, but so for discussion.
Yeah, well,
That's the bill, Delegate Hill. There's no amendments.
There's no amendments. So do you want to move the bill?
I have questions.
I have questions too, but I move the bill so we can have questions.
For the purposes of discussion. So it's been moved.
Second.
All right, it's been moved and seconded. All right, now we're going to open it for discussion. Let me start with the members and then I'll ask who wants to be heard on this bill. Delegate Hill.
Yes, so thank you. I like the intent. I'm not clear what happens when those aren't there. So, I mean, for many years, I've been watching people get discharged from hospitals and facilities of all types with discharge notes that said discharge to the street or discharge to, wherever. So I understand that we're putting prohibitions on that. I'm not clear on what that means and what that means for reimbursement if there's no place for the person to go. And if the person can leave on their own, and if that's, without, AOA, without medical clearance and who's responsible. I really need to understand if we don't have places for folks to go, what does that mean? They stay rent-free or they stay without insurance coverage or what happens?
And that's why we're having the discussion, because I think those are the outstanding questions and you've defined them very clearly as to why this bill has stalled in the past and also why we want to take action. Delegate Chisholm.
Thank you, Madam Chair. I've been trying to read all the witnesses in here, and it seems like one common theme from all the unfavorables is this is duplicative and they're already doing a lot of that. And I guess, and the other issue I see in here that hopefully somebody can answer is it seems as though if somebody leaves against their will, and obviously you can't necessarily force somebody to stay in one of these facilities if they leave. Sounds like most of them already have protocols in place, but does this add an extra burden to them? I don't know who's best to answer those questions, but is it duplicative? Are we already doing most of those things? What's the difference between what we're already doing in this bill? And then secondly, what happens in some of these unique situations where there are already protocols in place, but they're very difficult situations, such as somebody wanting to leave against medical advice?
Thank you, Delegate Chisholm. And we're going to get all the questions from the members on record, and then we're going to turn to the stakeholders. Delegate Lopez. Oh, you're on mute.
There you go. Sorry about that. I should have put my hand down. This might be the only time I say this, but Delegate Chisholm shared my concerns and expressed them. So I thank you, Delegate.
All right. Thank you, Delegate Lopez. Delegate Alston.
Hello. Sorry about that.
That's
So I have one major question, which is, what happens when we're keeping people who don't have a place to go? What is that doing for our overall emergency room wait time and the lack of beds that we have in our whole system? And I'd also like to hear from Ms. Hessler. I'm not sure if she's had an opportunity to respond, but I know she has some concerns for her clients. I'd like to hear what their perspective is as well. Thank you.
Thank you, Delegate Alston. So I wanted to hear from all the members because we know that we've got work to do, but we want to do it because this is an ongoing challenge. And I think the members have defined it as that we've got folks that are going from recovery to straight into recurrence to recovery to recurrence. And so we're trying to figure out how to help them. So I'm going to go to Ms. Seacott and then to Ms. Hessler.
Thank you, Madam Chair. So my client, the Maryland Addiction Directors Council, opposes the bill as written because of what we've just been talking about, the redundancy to existing regulations and accreditation standards. As you all heard at the hearing, there seems to be consensus that the good actors are abiding by existing laws and the bad actors aren't. So I just want to put out there an idea, perhaps a study to look at the issues related to discharge and linkages to care and between the different levels of care, and make recommendations related to the improvements in standards and or the enforcement, if that's what's really needed.
Thank you, Ms. Seacott. Ms. Hessler.
Thank you, Madam Chair. And first, I want to say thank you so much to the bill sponsor and his staff for their work on this effort. We have been in communication. I'm here representing the Recovery Housing and Treatment Center Coalition of Maryland. Our members are comprised of various levels of care, anywhere from inpatient, outpatient, group homes of all different levels to recovery housing. So we certainly understand the importance of this bill, but share some concerns that Ann just mentioned regarding duplicative efforts and some laws that have already been passed that aren't being enforced. So we would concur that a study would be wonderful to get some data and really all sit down at the table, bring stakeholders together and figure out best steps forward as we can address some of these bad actors.
Thank you very much. Ms. Lowe. Oh, you're on mute. Ms. Lowe, you're on mute. You go ahead, Ms. Lowe. Ms. Lowe, you're unmuted, but we still can't hear you. Do you have headphones on? Ms. Bissett, we can't hear Ms. Lowe.
Can you hear me?
We can hear you.
Okay, mute yourself, Lisa, and I'm going to turn the camera around.
Perfect, thank you.
For those of you that are not aware, turn your volume down, Lisa. We're getting the feedback. Delegate Howard is still out. He was diagnosed with COVID yesterday. So we're trying to handle this in his absence. So I'm going to turn my computer around to Lisa since we're in the same office and just let her speak from here.
Perfect, thank you.
You're on there.
I am.
You can't see it.
Oh, okay. So is this good?
Yes, go ahead. Go ahead.
I can't hear them.
Ms. Lowe, go ahead.
Can you hear me?
Yes, yes, we can.
We can't hear you.
We can hear you, so go ahead.
Robin.
All right, well, we seem to be having technical difficulties. We are going to hold this bill and revisit it tomorrow.
Thank you.
That's my chief of staff stepping next door.
Yeah.
To let them know that they can hear us. We can hear them.
So Rory has fixed it.
Okay. Is this good?
Yes, go ahead.
Okay. So regarding to the discharge to the streets, I can't, I'm listening to myself. If we don't,
I gotta turn this. Can't. Hold on. We're sorry. Let me get Rory again.
I actually have to conclude this meeting because I have to get the members back to the floor.
Okay.
We're going to bring this, we're going to
Let
have
me
a
just
discussion.
answer the questions then, and I don't have to hear you. I can't really respond when I'm listening to my own self in my ear. So regarding the discharges and not having places to go, some of the providers, the ones who are unfavorable and say this is a redundant bill, they're already in compliance with COMAR. COMAR says under treatment plans, current COMAR says a program shall develop a written treatment plan with the participation of the patient based on comprehensive assessment and patient placement criteria. In the treatment plan, the patient participates in that. So only the patients who want to go to a next level of care or a halfway house are going to go. Otherwise, it's not going to be in their treatment plan. If they leave against medical advice, or they leave before the treatment plan, or they sit down with the treatment planner and say, I don't want to continue service, then their treatment plan is going to say that. So in current COMAR, it says that the discharge plan is based on the treatment plan. But when you get to the discharge part of COMAR, it does not bring that back and say it. It says, continuing service recommendations and summary of transition process. It says the extent of the individual's involvement in the discharge plan. It does not say refer people to these places based on the treatment plan. It implies that. And so the providers who are already doing that, because that is implied by current COMAR, and that's the way they read it, they say this is duplicative. We don't need another regulation saying the same thing. Other treatment providers read it differently, and they are the ones discharging to the street. Now, if many of our providers are providing good discharges and getting their folks into the next level of care based on the treatment plans, but other providers aren't, well, the providers that aren't can learn to do what the providers that are doing it. There's not going to be a backlog. There's not going to be, this backlog of patients who can't find beds, because the providers that are reading COMAR to say, we need to discharge these people appropriately, they're doing it. And so it proves that that can happen. Now, then you've got the treatment providers who, don't want to do that level of service, and they're opposing it. So the problem is what the difference is between this bill and existing COMAR is it simply clarifies existing language under discharge plan to match the sentence that is already in the treatment part of COMAR. Discharge comes right under the treatment in existing COMAR. So good discharge planners are not keeping people longer than 30 days. So bad treatment providers don't have to keep people longer than 30 days either. And Ms. Peacott's proposal, this is the 8th year of this bill. And as Ms. Seacott may remember, we did a study. Ingvild Olsen chaired that study. It met during the summer. We met 5 times or so, and then there were no more meetings, and there wasn't a report. This is simply to provide what's already in COMAR.
To our members, I don't think she can hear me.
Madam Chair.
Now
I'm going to turn you up so I can.
Yes, Delegate Hutchinson. I know I need to
Motion to adjourn.
Second.
Second.
I'm gonna have to adjourn the meeting. We will revisit this bill